We are going to speak about echocardiographic evaluation of coronary arteries in different congenital heart disease. To start with, I would like you to look at this movie clip and what do you think about the left coronary artery? For those who think this is normal coronary artery, I would like you to wait until later on. And for those who think it's not normal, can you tell me what kind of abnormality you can see? So coronary arteries is a very important subject associated with congenital heart disease. First of all, this is a beautiful cartoon showing this is the right coronary artery arising from the right coronary sinus, and this is the left coronary artery, which give rise to left anterior descending and circumflex arteries, and also originate from the left coronary sinus. We need to have an idea about the distribution of the coronary arteries to the myocardium. As you can see here, this area is supplied by the left coronary artery in addition to anterior part of the right ventricle, whereas the posterior aspect of the interventricular septum is supplied by the right coronary artery. This is a beautiful anatomy for a normal coronary arteries, in which this is the left coronary artery, which give rise to left anterior descending artery and the circumflex. And this is the right coronary sinus, give rise to the right coronary artery with its branching. So what are the classification of congenital coronary artery abnormalities? We have four major classification. First of all, the anomalies of the coronary artery origin, in which we will look at origin of one or more coronary arteries from the pulmonary artery, anomalous origin from the aorta, single coronary artery ostium, and then abnormalities with the ostium of the coronary artery itself. The second classification, we have anomalies of the course and the distribution of the coronary artery. The third classification, we have anomalies in the termination, in which we will have fistulas formation. And there is the last category here is the anomalies associated with congenital heart disease, such as tetralogy of Fallot, TGA, corrected TGA, double outlet right ventricle, truncus arteriosus, pulmonary artery with the VSD, and hypoplastic left heart syndrome. We will mention a few of these associations later on in our talk. This is a nice cartoon by Nitter, and it's showing the different classification. Here is the anomalous origin of the left coronary artery from the pulmonary artery, with a lot of collaterals from the right coronary artery. We have here abnormalities associated with the transposition of great arteries, and we have anomalies of the coronary artery course and distribution, and here we have fistulas formation and communication of the coronary artery to the different chambers of the heart, and here we have associated anomalies with certain congenital heart disease. In this case here we have tetralogy of Fallot, in which the left anterior descending artery is passing anterior to the right ventricular outflow tract. Among the studies done to evaluate the incidence of coronary artery abnormalities in the population, we have here is a large study by Mayo Clinic looking at 126,000 angiograms, and they found there is around 1 to 1.5% coronary artery abnormalities, in which 90% implicate the origin and distribution, and then in about 10% it is abnormal fistulas. From these abnormalities with the coronary arteries, we have in 80% they are benign abnormalities, or we can call it not significant, and then we have in the rest of the 20% we have it's a clinically significant. That means the coronary artery is most likely will cause either sudden cardiac death or ischemia or chest pain during exercise. There is different studies from the USA database showing the sudden cardiac death related coronary artery abnormalities, and in some series we have up to 11% showing that there is abnormalities related to coronary arteries, and in another study there is about 23% associated abnormality with a coronary artery. So it is an important cause of sudden cardiac death. If we look into sudden cardiac death and ischemia in children, we have different main causes of sudden cardiac death in children. One of them is the coronary artery malformations. Other causes are maybe related to congenital heart disease itself. So in evaluation of coronary artery, we have to use the standard views and in addition to modified views. So we need to use the parasternal short axis, and also we can modify it to look for either the left or the right coronary artery by clockwise rotation or counterclockwise rotation of the transducer. Also, we can look at the parasternal long axis views and see the bifurcation of the left coronary artery and the proximal LAD. So we can use modified parasternal long axis. Also, we can look at the origin of the right coronary artery and the left coronary artery from the aorta by the parasternal long axis. In subcostal views, we can look at the bifurcation of the left coronary artery, and then we can look at anomalous left coronary artery or circumflex. In high parasternal views, we can look at the intramural course, as we will see in further cases. So here the parasternal short axis, and then you will rotate clockwise to look at the origin. Also, you can go high parasternal short axis, and then you can see if there is any intramural courses. So let's look at the normal coronary artery here. You can see this is the aorta, and this is the pulmonary artery, and we have the left coronary artery is nicely seen with its two branching here. This is the left anterior descending, and this is the circumflex artery. And when we put the color Doppler, it's very important to see the direction of the color flow in the coronary artery. You can see here there is a blue color, and this is the coronary artery vein. This is the coronary vein, and the red color is the coronary artery itself. And this is also the right coronary artery can be seen easily originating from the right coronary sinus. And when we put the color Doppler, we can see there is a normal color flow in this segment here. So this is the right coronary artery originating from the aorta with its color corresponding. This is a beautiful anatomy by CT scan in which you can look at the right coronary artery and the left coronary artery originating from the coronary sinuses with a normal branching. First classification we are looking at is the anomalies of the coronary artery origin, and the famous example of this is ALCAPA. It's anomalous left coronary artery from the pulmonary artery. It's also called bland white girdle syndrome, and then it was first reported by Brooke in 1887. The incidence is about 0.25 to 0.5 of all congenital heart disease. It was estimated is in about 1 in 300,000 live birth. The first year mortality for this abnormality is about 80 to 90%, so high mortality, and it can be associated with other congenital heart disease in about 10%. And this is a cartoon showing that the left coronary artery, instead of coming from the left coronary sinus, it's coming from the pulmonary artery. And you can see here there is a lot of collaterals because it is the main supply for the left coronary artery. and usually the blood flow is coming from the coronary artery itself into the pulmonary artery. So there is a collateral from the right coronary artery to the left coronary artery, and then the blood flow is going to the pulmonary artery. So this is my favorite case. This is Dania. She's a 4-month-old girl, known case of dilated cardiomyopathy, and she was referred to our center at the age of 4 months. You can see here how is the left ventricular function is really depressed with wall motion abnormalities. This is the color flow, and then at the septum here you can see there is many color on the septum, which might lead to a suggestion of some collaterals. But if you look at the right coronary artery here, you can see there is a dilated right coronary artery with increased blood flow, and this is the first hint that this patient might have coronary artery abnormality. This is the short axis showing the poor left ventricular function, and this is the apical four-chamber view showing that there is a significant mitral valve regurgitation because there will be papillary muscle dysfunction, and this will affect the function of the mitral valve, and usually you will have a significant mitral valve regurgitation. So when we looked at the coronary arteries of this patient, this is the aorta here and this is the pulmonary artery. We could see there's abnormal flow coming into the pulmonary artery, and when you look carefully here you can see that there is the two branching are joining together, and this is going into the pulmonary artery, and this is the left anterior descending, and this is the circumflex, and you can see that the color flow is reversed in this patient. This is a zoomed view here. You can see this is the LAD with the reversed flow, and this is the circumflex, and there is a clear jet into the pulmonary artery, and this is the usual site of connection, is the lateral part of the pulmonary artery. This is another view showing the same finding. When we look at the right coronary artery here, you can see that the right coronary artery is dilated with increased flow, and this should be the first hint that there is abnormalities in this coronary arteries. This is the ECG of the same patient, which shows a deep Q wave here, and then you will have ST segment depression and ST segment elevation, pointing towards infarction and ischemia. This is a 10-month follow-up of the same patient. You can see that after surgery, the patient went for surgery immediately upon presentation to our clinic, and then 10 months later she had perfectly normal left ventricular function. And when you look at the here at the apical fourth chamber, you can see hardly there is a minimal mitral valve regurgitation. But if you look at the papillary muscle, there is increased echogenicity. That means there is a fibrosis of the papillary muscle from the previous ischemic changes. This is the patient when she is at the 8 years of age, and she has a normal left ventricular function and minimal mitral valve regurgitation. This is another patient who was referred to our center rather late. The patient referred at the age of 10 months with a dilated cardiomyopathy, but when we looked carefully into this patient, this is the aorta, and you can see that the right coronary artery is dilated, and this is the pulmonary artery, and clearly you can see there is a left coronary artery is originating from the pulmonary artery, and you can see that the left coronary artery has a reversed flow into the pulmonary artery. This is the movie clip of the same patient. You can see that the left coronary artery is originating from the the pulmonary artery, and the right coronary artery is dilated. This is the same patient, and you can see the flow from the left coronary artery into the pulmonary artery very nicely, and this is only with anomalous left coronary artery from the pulmonary artery. Transesophageal echo can help us also in looking at the coronary arteries in these patients. So this is the origin of the left coronary artery from the pulmonary artery. This is 0 degree high mid-esophageal view. This is the left coronary artery arising from the pulmonary artery. This is with color. You can see the color flow into the pulmonary artery from this anomalous left coronary artery. So this patient has ALCAPA, and he was referred late to our cardiac center, although a late referral, but we have successful surgical repair. This is the tunnel which connected the left coronary artery into the to the aorta, and this is the tunnel from another view. After repair of the coronary artery from the aorta, then we have to look into the pulmonary artery and make sure that there is no stenosis in the pulmonary artery due to the reimplantation. And you can see here there is a normal flow in the pulmonary artery, which signify good repair of this patient. This is the immediate post-operative left ventricular function. It is acceptable for this patient because he was referred late to our center. And this is 1 year follow-up of the same patient. You can see beautiful the connection between the left coronary artery and the aorta with a normal color flow in the left coronary artery. So this is successful repair of this patient. When we look at the left ventricular function, it is improving left ventricular function. There is a slightly depressed left ventricular function, but overall improving from the presentation. Now we came back to the first case I have showed you. So what do you think? Is this normal left coronary artery or abnormal left coronary artery? Some of you, they said this is a normal left coronary artery because it is connecting to the aorta and there is no obvious abnormality. The others said that this is not normal left coronary artery because you expect that the left coronary artery usually is tapering down as it goes distal, but this one is not really tapering down. It has a different caliber. Actually, when we have this patient referred to our center, you can see here that this is what's supposed to be left coronary artery, but the color flow is reversed actually. So you expect that the blood will go from proximal here to the distal with a red signal, but here it's completely blue and the circumflex is red. So it is actually abnormal flow in this left coronary artery, and if you look carefully, there is many collaterals here around the pulmonary artery route. Then we scan the right coronary artery, and you can see that the right coronary artery is slightly dilated, and you can see there is many collaterals here in the right ventricular outflow tract. So we took this patient for further delineation of the coronary arteries, and the first injection was in retrograde fashion to the ascending aorta here. You can see that the first, at the beginning of the injection, you can see that the right coronary artery is ossified, and then later on you will see that the left coronary artery is ossified, and you can see there's also a jet into the main pulmonary artery. We'll go slowly on this injection here. So this is the injection. You can see that the right coronary artery is delineated, and then after that the left coronary artery is delineated, and when you look carefully there is a flow into the main pulmonary artery. Okay, then we went into a selective angiogram of the right coronary artery to look exactly at the coronary artery. So here, this is the injection of the right coronary artery. There is a lot of collaterals towards the left coronary artery in the LAD and the circumflex, and then you can see the blood is coming into the pulmonary artery. So this is ALCAPA with unusual site of insertion. 3 months after surgical repair of the same patient, you can see we have a normal blood flow in the left coronary artery with its branches, in addition to a normal left ventricular function with minimal mitral valve regurgitation. Here is the CT scan angio for ALCAPA, in which you can see that this is the right coronary artery with a lot of collaterals to the left coronary artery, and then the left coronary artery is coming out of the pulmonary artery, which is here shown by green color in the pulmonary artery. This is a lateral view showing that the left coronary artery is coming out of the pulmonary artery, and also here it's showing with a zoomed view. Anomalous left coronary artery from the pulmonary artery doesn't always present in neonatal or infancy. We have reported cases in adult life. For example, we have this case who presented to our cardiac center at the age of 32 years old, and her first echo was reported to be normal left ventricular function with mild mitral valve regurgitation. She again presented on 2015 with a palpitation. A repeated echo showed also reasonable left ventricular function, but they noticed that there are some color signals on the wall of the left ventricle as well as in the septum. Then the patient went for cardiac catheterization to look at the coronary arteries. The first injection was done on the right coronary artery here, and you can see that the right coronary artery is dilated and there is a lot of collaterals into the left coronary artery territory. And then after that, this is the lateral injection on the right coronary artery, which is dilated, and there is a lot of collaterals to the pulmonary artery, and then you can see that the pulmonary artery is obesified by the left coronary artery connection. This is the CT scan of the same patient showing dilated right coronary artery with a lot of collaterals to the left coronary artery, and then it is going into to the main pulmonary artery. So here is the lateral view showing the right coronary artery with a lot of dilatation and then insertion to the lateral part of the pulmonary artery. Anomalous coronary artery from the pulmonary artery is not confined only for left coronary system, but also it has been reported with the right coronary artery. And in this case here, we can see that the right coronary artery is originating from the main pulmonary artery on the this view showing that the right coronary artery is coming out of the main pulmonary artery.